Bleeding during pregnancy is one of the most intense situations you're absolutely going to face in clinical practice. And you can bet it's a high-yield topic on your nursing exams. So in this study guide, we're going to break down exactly what you need to know to assess the situation and act with total confidence. Okay, this right here, this is the single most important rule to remember. Vaginal bleeding during pregnancy is always a red flag. It's never, ever considered normal, and it demands that we investigate it immediately. The stakes are just incredibly high for both mom and baby, so let's get right into what could be causing it. So here's our game plan. We'll start with a quick urgent overview. Then we'll dive into early pregnancy bleeding and molar pregnancies. From there, it's on to late pregnancy bleeding, and we're going to wrap it all up by putting your knowledge to the test with some NCLEX style questions and a clinical case scenario. Let's do it. Okay, so the very first step in trying to figure out the cause of bleeding, what we call making a differential diagnosis, is knowing when it's happening. The trimester gives you a massive clue about what you're most likely dealing with. I want you to think of this as your mental map. In that first trimester, our biggest worries are spontaneous abortion and ectopic pregnancy. The second trimester is often when we might think about gestational trophoblastic disease. And then in the third trimester, it's all about the two big placental emergencies, previa and abruptio. So let's start breaking these down one by one. Let's kick things off with the first trimester. You know, bleeding during this period is sadly common, but it always requires immediate attention. We're going to focus on the two most critical conditions, spontaneous abortion and ectopic pregnancy. First up is spontaneous abortion. Now, clinically, this just means a pregnancy that ends on its own before the baby is viable, which we mark at 20 weeks. But here's a really crucial point for your patient care. While we use the term abortion in our charting, we always use the term miscarriage when we talk to our clients. It's just clearer, it's way more empathetic, and it avoids a lot of potential distress. So what's really behind a miscarriage? Well, lots of things can contribute, right? From uncontrolled diabetes to infections. But the most common cause by far is a chromosomal abnormality. And really, this just means that in many cases, the pregnancy simply wasn't viable right from the very beginning. Okay, this table, you're going to want to screenshot this. It is a fantastic study tool for classifying the type of miscarriage. Just notice the key differences. With a threatened abortion, you'll see some spotting, but the cervix is still closed. But once that cervix opens and the bleeding picks up, it becomes inevitable or incomplete, depending on whether tissue is passed. These little distinctions are absolutely vital for your assessment. So when a client comes in with bleeding, these are your priorities. First, you've got to quantify that blood loss. Doing a pad count is non-negotiable. Keep them on bed rest, and crucially, avoid doing vaginal exams because they can actually make the bleeding worse. A key instruction, and one that's often tested, is to have the client save any tissue that's passed. This helps us figure out if the miscarriage is complete. And of course, never forget RhoGAM for an Rh-negative mom and the profound need for emotional support. Now let's talk about a true medical emergency, ectopic pregnancy. This is when the fertilized egg implants outside the uterus, and usually it's in a fallopian tube. The problem is that tube was never designed to stretch, so as the pregnancy grows, it can rupture, causing a life-threatening internal hemorrhage. It's a major cause of infertility and a leading cause of maternal death in the first trimester. So how do you spot one? Well, it comes down to this classic triad of symptoms: one-sided stabbing pain, a missed period, and some spotting. But, and this is the big one, if that tube ruptures, there is one sign that just screams emergency: referred shoulder pain. That's from internal bleeding irritating the diaphragm. So if your patient says their shoulder hurts, you need to think rupture and you need to act immediately. Okay, let's move on to a less common but very important cause of early pregnancy bleeding: gestational trophoblastic disease, which you'll also hear called a molar pregnancy. With GTD, something goes wrong with the genetics right at fertilization. So instead of an embryo developing, the placental tissue, the trophoblasts, it just grows uncontrollably into this mass of grape-like cysts. And because that trophoblastic tissue is what produces HCG, this abnormal growth creates a massive surge of the hormone. There is no viable fetus, and this condition carries a pretty significant risk of developing into choriocarcinoma, which is a rare but very aggressive cancer. Now, there are two types, and the distinction is really key for exams. In a complete mole, all of the genetic material is paternal. There's no fetus at all, and the risk of choriocarcinoma is higher, around 20%. In a partial mole, you have both maternal and paternal genetics. You might see some abnormal fetal parts, and the cancer risk is lower at about 6%. The assessment findings here are very distinct. That massive HCG production we just talked about, well, it leads to severe nausea and vomiting, which we call hyperemesis gravidarum. The uterus also grows much, much faster than you'd expect for the gestational age. And the bleeding is a classic sign. It's often a dark brown discharge, sometimes described as looking like prune juice. All right, let's shift gears and jump to the third trimester. Bleeding now is a completely different ballgame, and it's often caused by two placental emergencies that you absolutely must be able to tell apart: placenta previa and abruptio placenta. So placenta previa is all about location. The placenta has implanted way too low in the uterus, and it's either partially or completely covering the cervix. The real danger comes later in the pregnancy as the cervix starts to soften and open up. That process tears the placental blood vessels, and that's what causes the bleeding. And here it is. This is the hallmark sign you have to burn into your memory. The bleeding in placenta previa is characteristically painless. Your patient will report a sudden gush of bright red blood, but when you palpate their abdomen, the uterus is soft. Your memory anchor couldn't be simpler. P placenta previa means painless. Okay, now for the complete opposite scenario, abruptio placenta. This isn't a problem of location, it's a problem of detachment. The placenta is prematurely pulling away from the uterine wall. This is an absolute emergency because it cuts off the baby's oxygen supply and can cause a catastrophic hemorrhage in the mother. And the signs are the polar opposite of previa. Abruptio placenta is all about pain, a sudden, intense, unrelenting uterine pain. The bleeding is often dark red, and the uterus becomes rigid and tender, what we call a board-like abdomen. This rigidity happens because blood is filling the uterus behind the placenta, irritating that uterine muscle. So here's your memory anchor. Abruptio placenta is awful pain. This right here is your ultimate high-yield summary for exams. Got it? Preeclampsia, painless, bright red blood, soft uterus. Abruptio, painful, dark red blood, rigid uterus. If you can master these three differentiators, you'll be set for pretty much any question on late-term bleeding. Okay, we've covered all the foundational knowledge. Now it's time to apply it. Let's bridge this over to clinical judgment and see how these exact concepts are tested on the NCLEX with a few practice questions. Take a look at this first question. We've got sharp, unilateral pain, some bleeding, and a missed period. Plus, there's a key risk factor, an IUD. What's your gut telling you? What is your initial suspicion? Take a second to think about it. If you chose B, ectopic pregnancy, you are exactly right. You have the classic triad of symptoms right there in the question, and that IUD is a major clue. It's great at preventing a uterine pregnancy, but if conception does happen, the risk of it being ectopic is significantly higher. Okay, here's our next one. The key word here is ruptured. What is the absolute classic finding for a ruptured ectopic pregnancy? Think back to what we just talked about. The answer is D. Like we emphasized, that referred shoulder pain is the cardinal sign of a tubal rupture. It's such a critical assessment finding because it signals a life-threatening hemorrhage from blood pooling under the diaphragm. Let's try one more, this time focusing on management. So you've got a preterm client at 32 weeks with placenta previa, and she is actively bleeding. Delivery could be imminent. What medication should you anticipate the doctor will order? The correct answer is A, betamethasone. Why? Because the client is preterm and actively bleeding, there's a really high chance this baby will need to be delivered early. Betamethasone is a corticosteroid that we give to the mother to speed up the development of the baby's lungs, and it dramatically improves their odds if they have to be born prematurely. All right, for our final section, let's move away from multiple choice and into a real-world scenario. This is where you have to put all the pieces together and make a critical clinical judgment call. Okay, listen closely to these clues. You've got a client in the third trimester. The bleeding is sudden, it's significant, and it's bright red. And then she gives you the magic words. It's not painful at all. What condition should be jumping to the very top of your list right now? So with all signs pointing directly to placenta previa, what is the most important thing you need to tell her to do right now over the phone? Think about immediate safety, what you need to assess, and what you absolutely must tell her to prevent this from getting any worse. And don't just think about that one instruction. I want you to consider the bigger picture. How does your clear, calm, and correct guidance in that single phone call set the stage for a safer outcome? Your clinical judgment in that one moment can change the entire course of care for this family. Thanks for studying with us today.